dryness, grittiness, foreign body sensation, redness, tiredness, itching, inability to open your eyes, then this video is for you, my friends. Welcome to iCare. This is Dr. Ankit Barot, consultant ophthalmologist at Vasudev Kutumbakam Eye Hospital, and today I am going to talk on dry eye disease. Now, first, as a patient do I expect from you? What we expect from the patient is that you give us a detailed and an elaborate history. Because if you just hit menopause, then you could be having symptoms of dry eye. If you have got ocular cicatricial pemphigoid, then you could be having dry eye. So whatever detailed history you have got to tell us. Are your symptoms more in the morning? Are they more in the evening? If your symptoms are more in the morning, it could be due to oil gland dysfunction called meibomian gland dysfunction. Are your symptoms more in the evening? Then that could be due to moderate dry eye. Then you also got to tell us what's the occupational environment you work in. Do you have exposure to dust, smoke, chemicals, winds directly blowing onto your eyes? Then these factors have to be taken into consideration, or rather you have to inform us that such factors you have got. What are the medications you are on? Do you use anti-BP medications? Do you use anti-cough medications? Are you on antidepressants? Are you on anti-anxiety drugs? Are you on antitussives? All these you have to inform us. What else do I expect from you, the patient? I also want you to tell us whether you have got dandruff in your hair. Have you got seborrheic dermatitis? Have you got dry eye or poor oral hygiene? Or do you wear contact lenses? If you wear contact lenses, then what's the time duration you are wearing it for? Do you sleep with your contact lenses? What are the cleaning solutions you use? Then what I expect is, do you have morning stiffness? If you have got that, you have to inform us. What's morning stiffness? That is, when you wake up in the morning, your joints are stiff. If your joints are stiff when you wake up in the morning, you have got to inform us. Now, you cannot tell me, the doctor, how this helps you. I'll tell you later that how it helps me, because it helps us to diagnose a disease which could be contributing to your dry eye. Now, the second question which comes to mind when a patient has got dry eye, which the patient asks us is, doctor, what's the cause? Now, for explaining the cause, I need you to understand an important concept called tear film. There is a tear film which is located between the eyeball and the eyelid. This tear film is formed of three layers, that is mucin, then we have got aqueous, and then we have got lipid. I told you three layers, that is mucin, inner, middle, aqueous, outer, lipid. Now this layer is important because it facilitates movement of the eyelid over the eyeball. It also washes away the debris. It also provides oxygen to the cornea because the cornea does not have any blood supply. It also keeps the cornea and conjunctiva moist, and it has also got antibacterial substances which are important in fighting off infections. And the first point which I mentioned was, it facilitates movement of eyelid over eyeball. Now, why does dry eye occur? Dry eye could be due to evaporative causes or due to deficient aqueous production, the middle layer. It could be deficient middle layer or deficient aqueous production, or it could be due to evaporative state. First, I'll come to evaporative state. That is, the aqueous evaporates. It could be due to extrinsic causes or it could be due to intrinsic causes. For extrinsic causes, what we have got is vitamin A deficiency. Inappropriate eye drop use, that is, you use eye drops by yourself or by consulting a pharmacist and you use it indefinitely, then and more frequently than required, then you can end up having dry eye. Then inappropriate contact lens wear, or if you have got an ocular surface disease called allergy. Now, coming to intrinsic causes. For intrinsic causes, we have got oil gland dysfunction, oil gland obstruction, we have got low blink rate, then we have got disorders of the eyelid aperture or the globe, etc. For meibomian gland dysfunction or oil gland dysfunction, the causes could be local to the eye or it could be body disease. For local diseases, we have got dandruff, then we have got allergy, then we have got trachoma, then we have got pemphigoid. For systemic disease, we have got acne, rosacea, we have got seborrheic dermatitis, ichthyosis, etc. If you have got any disease in the body, please inform us. If you have got any local disease in the eye, we will find out, but if you inform us, it helps us. If you have got a low blink rate, that also could be a cause. Low blink rate could be due to computer and visual display terminal syndrome. It could also be due to Parkinsonism. Now, if you got a disorder of eyelid globe or eyelid aperture, then also you could be having dry eye disease. If you have got an eyelid defect called coloboma, then you could be having dry eye disease. If you have got exophthalmos or eyeball bulging due to thyroid eye disease, eyeball bulging due to myopia, due to craniostenosis, then you could be having dry eye disease. If you have got ectropion, then you could be having a dry eye disease. If you got Bell's palsy, then you could be having dry eye disease. So these were all the causes of aqueous or rather evaporation of aqueous causes. Now I'll come to aqueous deficiency causes. When is the aqueous deficient? So we can classify it as Sjogren's syndrome associated or non-Sjogren's syndrome associated. For Sjogren's syndrome, we have got primary Sjogren's or secondary Sjogren's. Secondary Sjogren's is when it is associated with a connective tissue disorder. Primary Sjogren's is when it is not associated with a connective tissue disorder. For secondary Sjogren's, we have got associations with connective tissue disorders like rheumatoid arthritis, systemic lupus erythematosus, primary biliary cirrhosis. Then we have got ITP, TTP. Then we have got Wegener's granulomatosis. Then we have got Waldenstrom's macroglobulinemia, etc. Primary Sjogren's is you don't have cause. Now I will come to non-Sjogren causes. For non-Sjogren causes, we have got primary lacrimal gland deficiencies. I have to tell you what is a lacrimal gland. Look, lacrimal gland is a gland located here on the inside surface here, and this lacrimal gland produces aqueous. These tears flow across the eye, they swim across the eye, and they go to a punctum here, and from there they go to down the throat through the nasolacrimal duct. Now, primary, if the tear forming gland or lacrimal gland is deficient, then you could be having issues. Secondary lacrimal gland issues could be due to amyloidosis. Then we have got graft versus host disease. There are many diseases which can cause secondary lacrimal gland deficiency. Lacrimal obstruction, if this gland is obstructed, then also you could be having dry eye like trachoma. Then you got Steven-Johnson syndrome, etc. Then important factor would be aging, diabetes mellitus, chronic contact lens use. If you have got fifth nerve issues, there are 12 cranial nerves. If you have got a fifth nerve issue, then also you could be having dry eye. Then if you got a seventh nerve issue called Bell's palsy, then also you could be having dry eye. As I said earlier, aging, diabetes mellitus, chronic contact lens wear, multiple neuromatosis, etc. are important causes of dry eye. Coming to causes, now you will ask us that, doctor, how do you manage it? Or rather, how do you diagnose that you have got dry eye? First, we have to see whether your tears are secreted in enough quantity. So that is assessment of tear secretion. Then we have to find out what's the volume of the secreted tear. Then we have to find out the clearance, whether they are clearing very fast or they are not clearing at all. Then we have to find out what's the stability of the tear film, and then we can find out what's the damage to the surface. There are many tests for these 5 categories, but it's difficult to detail it in a small YouTube lecture. So what I'll do is I'll make another lecture later, but I'll tell you 3 basic tests which are very important and which are done by almost everyone. One is Schirmer's, another is tear breakup time, and last one is ocular surface staining by fluorescein. So first is Schirmer's. Now in Schirmer's test, what we do is we'll place 5 mm by 35 mm white Waterman filter paper for number 41 strips onto the outer corners of your eye, and when we put it on the outer corners of the eye, we see how much wetting of the filter paper occurs. That is how much wetting of the Schirmer's strip occurs. If it's less than 5 mm, we consider it as an abnormality. Now, coming to tear breakup time. If the tear breakup time is less than 5 seconds, we consider it abnormal. We'll stain your surface of the eye. Then when a random spot occurs on the tear film, not a spot at a pinpoint location, but a random spot across the tear film. When the random spot occurs, if the random spot occurs less than 5 seconds, we consider it as abnormal. There are multiple methods for tear breakup time. There are invasive as well as non-invasive methods. But if it's less than 5 seconds, then we consider it as abnormal. Then the last is staining by fluorescein. When we stain your surface by fluorescein, then we can pick up punctate epithelial defects. Then we can find out epithelial defects. There are also lissamine grain lissamine grain for dye which can be used. Also there is rose bengal dye which can be used to test your ocular surface. This was diagnostic tests. Now coming to management. Now what we want is ocular comfort for you, and we also want improvement in your lifestyle, or rather improvement in the quality of life you are living. So there are 8 strategies for management of dry eye disease. One is avoidance of exacerbating factors, then is lid hygiene, then we have got tear substitutes, then we have got tear retention, tear stimulation, then we have got biological tear substitutes, then we have got anti-inflammatory therapy, and then we have got essential fatty acids. Now what's important, starting with avoidance of exacerbating factors. We want you to avoid dust, smoke, chemicals, direct wind. We want you to blink more often. Rapid blinking and blinking more often is important. Lid hygiene, if you have got oil gland dysfunction or meibomian gland dysfunction, we want you to do a lid massage, warm fomentation. If you don't know what's meibomian gland dysfunction or oil gland dysfunction, consult your ophthalmologist. If it's more severe, he will treat it accordingly. Then we have got tear substitutes. Now these tear substitutes could be classified as having preservatives or could be preservative free. If they are with preservatives, we use it in mild dry eye. If it's a severe dry eye, then we use preservative free eye drops. We have also got eye drops and gel and ointments. Gel and ointments have got higher retention time, so we use it in severe dry eye. For mild dry eye, we use eye drops. Now the ones which are used in severe dry eye, that is gel and ointment, have got a blurring effect. That is, they have got an effect on blurring of vision, but you have to bear it with it, because for severe dry eye we have to use gel and ointments and they are more comforting. Now coming to tear retention, we have got 4 options for tear retention, that is punctal occlusion, then we have got contact lenses, then we have got spectacles, and then we have got surgery. Surgery is called tarsography, in which we decrease the fissure height, that is this fissure, this height is decreased, and from that the evaporation of tears is decreased. Then we have got contact lens. We use scleral contact lenses which decreases the evaporation and helps in healing of the epithelium. Then we have got glasses which will be airtight, and this increases the humidity around the eye and decreases evaporative aqueous loss. Now coming to punctal occlusion, I have to tell you what's a punctum. First I told you that tears are formed here in the lacrimal gland. It's somewhere down or beneath here, and they swim across the eye and they go to a hole here. The hole here is called punctum. If we occlude the punctum, then we could have decreased dry eye. But what we want the precaution to take is that your inflammation is controlled, because this tear flowing through will wash debris or noxious substances. So this gets washed away. So the inflammation has to be controlled. We want the inflammation to be under control before we are plugging the hole. So this hole could be plugged by surgery, by thermal cautery, or it could be punctal plug. Now this punctal plug could be temporary or it could be permanent. Now the ones which are permanent could be collagen or acrylic. You have to take care that you are not allergic to collagen or acrylic. You don't have ectropion of the punctum, that is, this punctum should not be everted so that there would be loss of the plug, or you should not be having nasolacrimal duct obstruction that negates the effect of the plug. Now for temporary, what we use is collagen or polymers. The life of this is 7 to 180 days, and if you want to remove it earlier, then you can do a saline irrigation. Now coming to, I have finished tear retention. Now I will come to tear stimulation. If you want to tears stimulate, then there are drugs under trial, but they are not cleared by the drug agencies. After they are cleared by the approved authorities, then we can discuss it in detail, and I'll make a video on that as well. Now coming to autologous or biological tear substitutes. For biological tear substitutes, we have got 3 things. One is platelet rich plasma, only plasma, and then we have got submandibular gland transplantation. First is plasma. What we do is we drop some blood from you, we'll centrifuge it, After centrifuging it, we have got a layer called plasma. We make eye drops from that plasma, and these are used in cases in which it is not responding to normal therapy. Then we have got platelet rich plasma. This platelet rich plasma is used when we want healing of epithelium. It has got growth factors which assists in healing of the epithelium. It also has mesenchymal factors. Now, coming to submandibular gland transplantation, which can be used in severe dry eye. Now, the seventh strategy which is important is anti-inflammatory therapy. The eighth strategy is essential fatty acids. Now, inflammation is an important component to dry eye. So, we can use anti-inflammatory agents like topical cyclosporin, topical corticosteroids, and oral tetracyclines. Topical cyclosporin is FDA approved and is a disease modifying agent, but it has to be used after consultation by an ophthalmologist. Topical corticosteroids have got their side effects, so they have to be used for limited period only and have to be used after consultation with an ophthalmologist. They have got their side effects, so don't use it after consultation with a pharmacist. Don't use it by self. Don't self-medicate. Use it only after consultation with an ophthalmologist. And we have got oral tetracyclines which have got anti-inflammatory activity such as doxycycline. It can be used twice a day, but exact frequency, all that has to be taken into consideration your meibomian gland dysfunction. We can decide on the amount of time which we want to give it for. Eighth strategy is essential fatty acids. What we want is omega-3 fatty acids. They reduce inflammation. That is, they reduce swelling on the surface, and they also contribute to the oil layer or lipid layer. I told you the tear film has got three layers. That is, inner was mucin, middle was aqueous, and the outer was lipid. So it contributes to the outer lipid layer. That is omega-3 fatty acids, which are available from flaxseed oil and fish oil. So I have told you 8 strategies for managing dry eye disease. I have tried my level best to cover all that is true dry eye disease. Even after this, if you have got a doubt or query, please post in the comment section below. Which strategy has been used by your ophthalmologist? You should mention in the comment below. And for more such videos, please smash the subscribe button. And thank you for watching.